Good morning, everyone, and welcome to our celebration of International Allied Health Professions Day. My name is Anne Tate, and I am the Chair of the Allied Health Professions Federation of Northern Ireland, also known as AHPFNI. Please turn your cameras off on your device. You can use the chat to send comments, pose questions, highlight who the questions are directed to, and we will reply with an answer after the session. You will see on your screen there is a poll consisting of 3 questions. We would appreciate if you could answer these at the start of the session, and then we will present the same 3 questions again to the close of the session, and we would ask you to answer them again. I'd like to introduce our keynote speaker, the Minister of Health, Mr. Robin Swan.
Good morning, and I'm privileged to be given this opportunity to join AHPFNI in celebrating Allied Health Professional Day. Firstly, I would like to put on record my thanks to the AHP workforce for your commitment and professionalism in these challenging times. I value and acknowledge the need for a skilled AHP workforce to support my department as it moves forward on its restructuring and rebuilding of the health and social system, particularly in strengthening community services, preventing hospital admissions, transforming elective outpatient services, and in establishing urgent care centre services. The strength of the allied health professionals is in part due to the collective diversity of the 13 individual AHP professions, which enables you to play key roles across the HSC in prevention, diagnosis, treatment and care. I also want to acknowledge your contribution in the work of other government departments and agencies. For instance, the work you do in education, supporting children with special educational needs, or your work in prison health. Today's webinar showcases the breadth and diversity of AHPs whilst demonstrating their individual worth in reshaping of the HSC. There are many examples of AHPs making a difference. AHPs are playing a key role in mental health services, providing advice to service users. OTs are working as part of the primary care multidisciplinary mental health teams. Speech and language therapists are supporting children and young people in our CAMS teams, and specialist dietitians are core enablers within our eating disorder services. As part of the reform of cancer services, therapeutic radiographers at the cancer centres in Belfast and Western Trust have extended their scope of practice. AHPs have always played major roles in rehabilitation services in areas such as stroke and pulmonary disease, and we have seen how recovery from COVID-19 provides a new set of challenge for rehabilitation. Successful rehabilitation is dependent on a range of professions, and AHPs, particularly dietitians, occupational therapists, physiotherapists and speech and language therapists, are key to successful recovery of a number of the consequences of COVID-19, such as muscle wastage, breathing, swallowing and communication difficulties. We also see many examples of how AHPs are delivering transformative, innovative and evidence-based services. First contact physios are helping transform certain services in primary care. Speech and language therapists and dietitians are reducing the number of vulnerable patients in our care homes, and learning disability services from choking. Podiatry-led foot care pathways are providing proactive, seamless models of care for patients diagnosed with diabetes, and paramedics are now treating more patients at the scene and referring an increasing number of patients to alternative services, reducing the number of patients that need to attend ED. These are just some of the examples where AHPs are making a difference. In closing, may I wish you all a very enjoyable and successful day.
Mr. Swan, thank you for taking the time to record this message and open our webinar. I'd like to introduce our Chief Allied Health Professions Officer, Jenny King.
Good morning all. I'm delighted to see so many of you have joined us this morning, and apologies, the IT always within Castle Buildings and within Stormont can never be relied on, so unfortunately there was a little bit of a lag in that video, but the Minister was very keen that to support AHP Day this year, and it was a fabulous opportunity to discuss the important role that allied health professions are making to his department in his plans over the next, his plans for reform and rebuild. as the Minister has said, this webinar is an opportunity to showcase a number of the remarkable ways within which AHPs can make a difference. He's referenced a number of them, and as you'll appreciate, it's extremely difficult to, really reflect on the absolute breadth and diversity of everything that we all do. I think when reflecting over the last couple of days on the examples which the Minister was able to reflect on, I also was able to think a little bit about some of the emerging and some of the really significant contributions that allied health professions are making, some of which have really come to the fore in the really last short number of weeks and months. I'm going to share a couple of those thoughts with you now. For me, one of the real changes over the last couple of months has been the emergence and the realization of the untapped potential that there is within the creative therapies that are part of our allied health professions group. So the art, music and drama therapists have really come to the fore, particularly as a really therapeutic, valuable aid in recovery of COVID-19. The need for the wider AHP input to mental health and to the strategic reform of mental health. But it is really encouraging to see that policymakers right across our system have now got a real understanding of some of our core AHP services within mental health, but also the creative, if that is the correct phrasing, but particularly the input that art, music and drama can make to that space. Another really sort of encouraging conversation that I'm going to share with you was in the context of one of the strategic reform boards, and I'm going to talk a little bit about the orthopaedic network. So without, when the orthopaedic strategic board met, I was, absolutely assured that the strategic board would need and ask for the input of physiotherapy and for the need for podiatry, and yes, they did. But what was really encouraging was that the clinical leads for those groups asked for and referenced before I or any of the other AHP that were representative on the board, the invaluable role that they wanted both the orthotists and prosthetists to have in the reform of orthopaedic services. And I think that is testament to the work that we are collectively doing, that those messages are really strong and clear across our system. Similarly, the same thing has happened with the review of ophthalmology services. The need for the orthoptists as a critical, crucial linchpin in that reform and rebuild has been really well recognised. And then on the other scale, a professional group which have literally been reflected right across every single piece of strategic work that's going on at the moment has been the diagnostic radiographers. So the role that the diagnostic radiographers are playing and will need to develop further is becoming extremely, apparent and referenced both in the acute surge for Nightingale, the intermediate care piece, again within Nightingale, the No More Silos work, the elective care centres, the reform of primary care. So across every single sector, we now have a real ask from policy for our input. And as I reflected and thought about this, I did begin to think, well, what is it about the allied health professions as a group that make us stand out? What is it about us that is really, really different, really unique? And I did think, well, is it the fact that, as we discussed at NICON, we're on the move across all programs of care, with the ability to have a positive impact from cradle to grave? Is it the workforce, second largest workforce that works right across health and social care, education, prison health, housing, communities. And yes, all of those things were really significant, but I think when I had the opportunity to reflect further on it, I actually thought, well, the clue's in the title. We're allied. We are allies. As a professional group, we are collectively an ally of professions across sectors, and that really is what gives us our strength and what makes us unique. Now, I did then look up the definition of what actually is an ally, and an ally, by definition, combines or unites a resource or a commodity for the collective benefit. And I did stop and think, well, if ever there was a time within health and social care, or globally, where that collective uniting ability for a resource was required, it is now. So my message to you today is to value that allied, value your allies. That's where our strength is. I do think this is our time. This is where that collective responsibility and accountability is what's needed in the system. We don't have continuously new resource, so it's being able to unite our collective strength and skill for that collective goal is, I think, what makes us unique. I'm absolutely delighted to have an opportunity to speak today and to welcome you to this webinar. I think it's been a fabulous piece of work by the AHPFNI, and it's brilliant to see this underway. And I'm really, really looking forward to hearing all of the various presentations. So really looking forward to it, and well done, everybody.
Thank you very much indeed. Jenny is going to stay with us for the rest of the morning. So, AHPFNI are 12 professional bodies representing 13 professions, and collectively we are the second largest professional grouping in healthcare after nursing and midwifery. There are now over 7,300 allied health professionals, also known as AHPs, working across health and social care. Our mission is to provide a collective independent leadership and representation on common issues that impact on our member professions in Northern Ireland. Our purpose is to promote interprofessional working, enable allied health professions to provide high quality care for patients, clients and their carers, and provide effective communication to all members in Northern Ireland. We have been proactively influencing at a strategic level on behalf of all AHPs in Northern Ireland. For example, writing to the Minister and Health Committee regarding workforce and the correct AHP leadership voice at key strategic senior tables in the Department of Health and the BHA. Indeed, we look forward to our meeting with Minister Swan on the 25th of November, and again we thank him for his openness to work with AHPFNI and support AHPs in Northern Ireland. We are collectively known as AHPs. However, not all our professions are as well known as others. I will list our professions for you. Physiotherapists, dietitians, speech and language therapists, diagnostic and therapeutic radiographers, occupational therapists, podiatrists, physicists, orthotists, art therapists, drama therapists, music therapists, paramedics and orthoptists. Our aim is to raise the profile of all AHPs in regard to roles and responsibilities, advanced clinical practice and leadership. We hope to change how you see us today from black and white to wonderful technicolor. Today we have decided our presentations are divided into 4 main areas to coincide with the Minister's priorities, which are the mental health strategy, cancer strategy, rehabilitation and transformation rebuild back better. Rather than have a predictable allied health professional within each category, we're going to reveal to you the extent to which we have diversified and show you our ability to work in areas not known as typical AHP specialties. You will also see how our professions work together as cohesive teams in areas you are probably not even aware we have expanded into, taken on additional roles and training, and ensuring waiting lists are reduced and that the patients receive a high standard of care at the right time. This has all been achieved by us not only working together, but also looking to the future in regard to transferability of skills, working across disciplines, reducing silos, and therefore improving the patient care pathway and the patient experience. Engaging with our managers and our professional bodies through the professional officers, while ensuring involving patients in change with co-production and co-design, putting forward well thought out proposals. Managers have seen the benefit of these and have enabled the changes to take place. Upskilling the AHP workforce is paramount to enabling change and transformation. Training programs have been sourced, funding has been made available for training to take place, and services have been improved. This is ongoing for each profession, and we are always looking to the future to develop further. Workforce planning is essential to ensure the future provision of services. Thanks must go to the Minister, Mr. Robin Swan, and to the Chief Allied Health Professions Officer, Jenny Keane, who you have just listened to. They provide a platform for AHPs and have assisted in providing some of the funding towards development and are listening to our ideas. We will also give you an insight into how we have adapted throughout COVID-19. AHPFNI decided to mark AHP International Day with a celebration that will recognise and inform everyone of the contribution that these 7,300 professionals bring to the health and social care services of Northern Ireland. Now, moving on to our presentations. Our first category is mental health, and we have 2 presentations for you.
Hello, my name is Ruth Sedgwick. I'm a speech and language therapist working within the Belfast Trust for the Acute Mental Health Inpatient Service. This is the first post of its kind in Northern Ireland. There was a significant gap in service, so hospital speech therapists were going on to the mental health wards, and they ultimately felt lacking in knowledge and experience of mental health disorders required to effectively and safely manage the patients, and they were also going on a very ad hoc basis. And so this post was born. It's a temporary post, a pilot funded to look at scoping out the need for speech and language therapy within mental health. I've been in post since January 2019, and I can wholeheartedly say that there is indeed a significant need for speech and language therapy within mental health. My experience of working with a wide range of patients with acquired communication and swallowing difficulties has given me the transferable skills for working within mental health. So there's a wide variety of patients that present to the unit with multiple comorbidities. Those include Parkinson's disease, Huntington's disease, brain injury, and dementia. So having this experience behind me has proved invaluable in providing effective speech therapy input. Being immersed within the unit itself for the last 18 months has allowed me to learn and expand my own knowledge base of mental health disorders and their impact on a person's communication and swallowing. It has certainly been a huge learning curve for me, and the SLT role continues to evolve as I learn. Patients are referred to myself then for assessment and management of communication and or swallowing issues. So these could be those patients that present with a progressive neurological disease or those who present with a mental health disorder such as schizophrenia or acute psychosis. The SLT role then within communication and mental health goes from the basics of supporting everyday communication of their needs to enabling decision making and facilitating key discussions around medications, treatment options and discharge planning. This includes supporting the assessment of capacity in relation to the new DAWS legislation. In terms of dysphagia and swallowing then, we know that unsafe eating behaviours such as cramming foods are very common and increase a person's risk of choking. Also, the use of antipsychotic medications can change a person's swallowing, so they can increase saliva production, they can decrease oromotor strength. So I can go in, assess and provide advice and support to the patient and staff in promoting safe eating and drinking behaviours and ultimately in helping to reduce the risk of choking and aspiration on the wards. So what's next? Well, at the minute I'm working on a quality improvement project. It's in the early stages and we're looking at standardising the process and improving patient safety with regards to handing over and communication of swallowing advice across the unit. We're also looking at improving mealtime experience across the 5 wards. But ultimately, I'm hoping to secure permanent funding for this post, as well as more commissioned SLT posts to fully establish ourselves within mental health services as an integral part of the team. As speech therapists, we really welcome the development of a mental health strategy and the appointment of an interim mental health champion, Siobhan O'Neill, and see this as a real opportunity to improve service user access to speech and language therapy within mental health. Thank you for listening.
Hello, my name is Eileen Tiffany and I'm a podiatrist with the Belfast Trust. Part of my role includes working with people experiencing homelessness. Within the Podiatry Outreach Project, I identified an opportunity for PPI with this traditionally hard to reach service group. I set up focus groups in 2 quite diverse homeless hostels to capture a wide range of views and opinions, as the spectrum of homelessness is really wide. With the help of my nursing colleagues, we've built up a very good relationship with service users over time, and this was key to having open, honest conversations where experiences were shared, ideas discussed to help shape the podiatry homeless service as we were moving forward. Different themes came out of the 2 focus groups. One of the hostels expressed a strong need and desire for support to help them to look after themselves and their own foot care. And from this, we produced foot care packs and information desks. We realised we needed to strengthen our communication with the hostel staff as they support the residents an awful lot. And the second hostel was the themes really there were expressions of gratitude and thanks, and the opportunity was taken at that time to say thanks for what you've been doing for us over this period of time. Again, we realised communication was key with our hostel staff, and we were also able to approach the subject of high DNA rates in mainstream service appointments. But from the information that we gathered from the focus group, we used this to tailor the service to ensure that those with the greatest medical risk and podiatric need received it, and those who were less at risk of ulceration and amputation benefited from the podiatry health promotion and enablement programme that we then put together. The Western Trust Podiatry Service are currently involved in a homeless healthcare project with nursing colleagues, and our aims really mirror each other in that we both want to improve the access, improve the health outcomes, and improve the service user experience for people experiencing homeless. And it's great to be able to share my learning with others. Thank you.
Thank you. Our second category is cancer, and we have 3 presentations.
My name is Carly Brown. I'm the clinical specialist radiographer at the Cancer Centre in Belfast City Hospital. This role places me in a very privileged position that enables me to establish a unique rapport with patients as their radiotherapy key worker. It also enables me to lead on innovative development initiatives within radiotherapy and to collaborate with colleagues for streamlining of supportive services. Which brings us to this AHP-led project of Feed NG, which saw the development of an outpatient NG feeding service for head and neck patients. Individuals diagnosed with head and neck cancer face many life-altering challenges. Imagine for a moment the anatomical structures and functions located within this relatively small area of the head and neck. Sense of taste, smell, sight, hearing, the ability to speak, breathe and swallow. These can all be negatively impacted not only by the position of the cancer, but also by the very treatments used in their management. With this in mind, it comes as no surprise that management of this complex patient group relies on specialist multi-professional input. As a result of treatment toxicities, it's very common for head and neck cancer patients to require nasogastric feeding to help supplement nutrition throughout a course of radiotherapy. Historically, this required admission to hospital for the duration that supportive feeding was required, as the infrastructure was not available to support any other means of service delivery. Historically, each profession was working uniprofessionally with the patient, and while at the time this was acceptable, we began to recognise that transformation to a more collaborative multi-professional approach would be required, where the patient was centre and uniprofessional silos would be no more. In the last 10 years, we have seen a 24% rise in head and neck cancer incidence within the UK, believed to be closely linked to the increasing prevalence of HPV or human papillomavirus. These viral-driven head and neck cancers bring a younger demographic of 30 to 55 years of age. This patient group tend to be more proactive in seeking out information and are keen to have an active role within their care. With thoughts of many weeks in hospital, becoming increasingly frustrated, missing out on life events, we find this group are more reluctant to admission for supportive feeding, and they want to remain at home. As we move away from the old model of paternalistic healthcare delivery to a model of shared decision-making, working in partnership with patients, we listened to our patients' concerns and we explored the option of developing a system of work and a pathway that would enable us to train and support patients in the self-management of NG feeding in an outpatient setting. We utilised the Safety Quality Belfast programme when initiating this project, as it provided a quality assured framework around which to develop our new service and engage all associated stakeholders. Service users have been a key part at every stage of development. This AHP-led service development initiative has maximised our use of resources, resulting in significant positive outcomes across areas of patient experience, cancer services, and finance. Most importantly, we have improved the patient experience, with greater than 1,000 days given back to patients, enabling them to stay at home at a time when they need the support of family the most. Patient focus groups from the outset highlighted this as being the most important factor for them. In service, fewer oncology outliers as a result of this, patients can now occupy what previously would have been a head and neck cancer patient's bed, ensuring that more patients are able to access this specialist care. We look at finance. 1,028 bed days saved amongst the head and neck cancer patient cohort over the last year period generates a gross saving of £609,604. By working together and sharing interprofessional information, we are able to establish an alternative management strategy for these patients, while also recognising the potential impact on the services as a whole. With these improvements to the pathway and the various elements it encompasses, we feel it demonstrates our trust's values: working together, excellence, openness and honesty, and compassion. We believe we now have the right people in the right place at the right time. Thank you.
We have already submitted an AHP combined workforce review to the Department of Health, describing the function, benefits and scope of ART psychotherapist work in Northern Ireland. I hope this report is available to you. Art therapy is a form of psychotherapy which uses art to communicate and focuses on the imaginative and creative life of the patient. It is a relevant intervention for issues where verbal approaches may be insufficient. It addresses trauma, abuse, developmental disorders, and a range of complex mental and physical conditions by the creation of new neural pathways and healing old wounds through multisensory and symbolic processing. In the cancer sector, an art therapist has been employed full-time for the last 12 years by a leading cancer charity, delivering an art therapy service to adults and children with cancer. This one art therapist offers extensive provision, including individual and group work, a drop-in facility at the RVH, art journaling, residentials and student placements. Student placements are also provided by the Trust. This is the only art therapist working in the cancer sector in Northern Ireland. This inclusive, accessible service at one time employed a bank of 7 sessional art therapists for outreach groups throughout NI. This was cut due to financial constraints. The situation in the cancer sector is indicative of our other fields of work throughout NI. We are committed and passionate workforce, highly skilled and highly qualified, but as a profession we feel underused, underpaid and undervalued. Whereas in the rest of the UK, art therapists are employed as valued members of multidisciplinary teams within NHS and other adult mental health units. For example, over 200 art therapists work full-time in CAMS units in England. In Northern Ireland, we have 1 part-time art therapist in such a unit and 2 other full-time posts within the NHS. There is growing recognition of the extent of psychological help needed in Northern Ireland. and art psychotherapy can act as an integral part of that help. A platform such as a funded pilot scheme, well documented in research, would give us opportunity to show our worth as a profession. Art therapy is a healing and cost-effective process, but there have been very limited opportunities in the NHS to demonstrate our effectiveness and show lasting benefits which art therapy process brings to patients. Examples of research in England show its long-term effectiveness and the improvement in the health of patients. We feel it is imperative to develop an art psychotherapy service within NHS cancer services and also more broadly across NHS mental health services. If this happens, it will align with the aims of the Northern Ireland Executive, that is to achieve outcomes of social well-being and delivering real and positive change in patients' lives. Reading our DOH report will expand knowledge of what we as a profession can accomplish given the opportunity. Thank you.
Bladder and bowel problems and issues with sexual health. These problems are embarrassing and distressing and can have a huge impact on things like mental and physical health, relationships, work and finances. As a team, we are well aware that those patients with pelvic cancers are likely to suffer pelvic health issues, but we never received many referrals for these. Back in 2015, we were fortunate to receive charitable funding, initially from Prostate Cancer UK and then from Macmillan. This allowed us to see what benefits physiotherapy could offer patients with prostate cancer and with some gynae and colorectal cancers. The prostate cancer service involves a joint nurse and physio-led pre-op clinic that runs on a weekly basis. The prehab service includes assessment of pelvic health and a digital rectal examination to assess pelvic floor muscle function. I advise the men in increasing physical activity levels, both aerobic and resistance training. I also advise on maintaining good bowel habits, bladder advice, fluid and dietary advice, and prescribe them a bespoke pelvic floor muscle home exercise program. I follow them up post-surgery for further rehab as required. I would also see men post-prostate cancer radiotherapy treatment, as many of those develop late effects. Due to the positive outcomes gained, the urology team has permanently funded this post. Prior to the start of the Macmillan project, colorectal and gynae cancer patients were not routinely seen by physiotherapy. The physiotherapy intervention has had excellent outcomes. A rectal cancer patient was quoted saying, "My life is transformed. I was on the verge of asking for a stoma bag again. I can't believe how much difference this treatment has made. I can feel my muscles working and have confidence again. I can go on holiday because I'm not worried about soiling myself." A gynae oncologist stated that patients concerned for the most part are young and motivated women who have undergone radical treatment for gynae cancers with a very good outlook in terms of the cancer, but are looking at 30+ years of dealing with some difficult fallout issues. Evidence shows that if these issues aren't addressed, patients will be referred from specialty to specialty with multiple vague complaints, undergoing futile investigations at a significant cost to the NHS. Seeing a pelvic health physio allows women the time to develop trust and build a relationship that is important in breaking down these psychological barriers and teasing apart the complex issues of pelvic health.
Thank you. Our third category is rehabilitation, and we have two presentations from that.
Hello, my name is Jane Hanley. I'm representing the British and Irish Orthotic Society, one of the aforementioned sort of slightly more unusual AHPs. But I'm so proud to be here today, and thank you for inviting me, and thanks for everyone's words. It's all very inspiring. Whenever I thought about rehabilitation, as Jenny and Anne alluded to, it's not normally associated with orthoptists. But rehabilitation, the definition, when I looked it up in the Cambridge Dictionary, is a process of restoration to good health when something has sort of stopped you living your best life, to quote the teenagers. And the process that could have stopped it could be a health impact, or could be the fact you're in prison, or the fact that you can't express yourself. And a lot of rehabilitation is understanding the barriers to people living their best life, to be able to drive their car, to have relationships, to be able to relate to people, to be able to go back to work. And a big impact on that is probably unrecognised, and that's vision, which is 80% of what we're doing now. And whenever I think about rehabilitation, I think of somebody I saw in my career who was 28 and had a huge stroke, and she was having difficulty communicating, and she couldn't use her phone. And whenever I assessed her vision, I realised that her near vision had gone. And we all know, especially me, at a certain age, when you take your reading glass off and try and look at your phone or look at anything, life becomes very difficult to understand. And she was able to communicate with them outside her life. And I was thinking about when we are in COVID, when all these patients cannot communicate face to face and they're reliant on tablets and things like that. So really the whole thing about visual loss, which is about 60% of patients who acquire brain injury or have stroke will have a visual loss. So don't forget that they may not be able to communicate their visual problems to you. So don't forget to use the orthoptists that are available in every trust throughout Northern Ireland. So that's all I'd like to say. Thank you very much, everyone.
Hello, I'm Jonathan Cousins-Booth and I'm the acting chair of the British Association for Music Therapy. I'm going to talk today about music therapy and rehabilitation. As music therapists, we are not only AHPs, and we're delighted to be AHPs and part of that family, but we're also psychological clinicians who hold master's level, entry level qualification and HCPC registration. Across Northern Ireland, we have 35 registered music therapists, and they contribute within the HSC 26% of all music therapy in Northern Ireland. However, at the moment, zero music therapists are employed directly by HSC. All of this is through projects and small bits of work throughout the year. The majority of this work is currently in adult disability and adult health D services, with minimal work in rehab, dementia, and mental health. So in terms of music therapy and rehabilitation, these are the predominant areas for music therapy, with one of the fastest growing evidence bases being that of the neurologic conditions and how music therapy can really help in those areas, including disorders of consciousness, acquired brain injury, and strokes. Although we're talking a bigger picture here, music therapy can play a key part at the moment in terms of COVID-19 rehab as well, within how it can help with pulmonary and respiratory conditions and within palliative care and bereavement support. So why music therapy and rehab? As with other AHPs, we provide a holistic approach. Yes, we can work on the physical, but also the psychological and the psychosocial. Music extends beyond specific languages or beyond culture to create that connection, no matter where somebody is at. And music therapy, beyond that of contracts or freelance work, it can really help to gel together an MDT. And there's quite a lot of research supporting music therapy as part of an MDT sees vastly increased patient and service user outcomes. And that, the quick take-home messages from my 3-minute presentation is that service users really highly value and really highly rate arts therapies. Improving access to these across the whole of Northern Ireland will improve service user outcomes. And when you're advertising or creating your next team, the psychological support that music therapists offer goes far beyond inpatient mental health settings. Innovative service design can really see music therapy be used to its full potential. Thank you.
So, hello everybody, my name is Sue Jennings. I don't have a video, I just have me, and some of my props and toys in the background, which I'm sure you can see. And I want to tell you about drama therapy, past, present and future in my 3 minutes. Drama therapy is not new. It is a very, very ancient craft and practice, well known to the ancient Greeks, well known to tribal societies. And when we look through history at different items of literature and play scripts, we again come across healing plays, healing performances. So we're looking at something old that's been brought into this century to address issues that we all have now. I was the founder of the British Association of Drama Therapists, and it has a good established working practice in the UK, and I'm sad to see that it's still got to develop further in Northern Ireland. And could I say now that anything I can do to support and help that, you only have to ask me. Drama therapists work in a variety of settings, in psychiatry, in day centres, in rehabilitation, with any age group from 0 to 90, we always say. Work has been developed in prisons, in maximum secure units. I did several programs in Broadmoor Secure Hospital, all of which have been written up, and the literature is there. And I think one of the people we have to thank too is a drama therapist called Louise Coombs, who did some amazing research that is now integrated into the NICE recommendations in psychiatry in the UK. So please do have a look for that. Where should it be going now? I notice that there is no drama therapy training in Northern Ireland. So it's very difficult when people have to travel across the water to the UK to even undertake a training. And I'm suggesting that maybe a first step would be to establish at least a foundation course. And from the foundation course, you would then have students who would go on placement. You would then therefore increase your staff in special education or in rehab or in hospitals. So I think Northern Ireland now needs to be proactive. It needs to acknowledge how important drama therapy is. Maybe we could have a mini online conference in a few months' time where different speakers can present and talk about the work and their application. It hasn't been without its struggles. Some people will remember that I used to be called the tambourine lady when I used to go and work in children's homes. That was what the social workers saw me as, someone to bring a bit of lightheartedness on a Friday afternoon. It's more than that. It's an in-depth master's level training with clinical and educational application. So join me, ask questions. I'll put my contact up on the board and let's start a dialogue about developing drama therapy in Northern Ireland in its own right and not riding on the backs of everything else. So welcome and thank you for listening.
Hello everyone, my name is Catherine Merkin and I'm the Joint Advanced Practitioner Clinical Lead Occupational Therapist in the Acute Care at Home team in the Southern Trust, and I'm going to talk about care in the time of COVID. So some background to Acute Care at Home then. We're a dedicated consultant-led multidisciplinary team including 4 occupational therapists. Our primary focus is on maintaining the older person at home or in their nursing home in the event of an acute illness or unexpected deterioration in their health. And we provide triage, assessment, diagnosis and treatment as an alternative to inpatient care. Our data has shown a reduced length of stay in comparison to a hospital admission. As OTs within the team then, we aim to support patients to maintain their independence. We use evidence-based assessment and treatment with a focus on rehabilitation. And we work to an extended scope of practice by completing clinical observations and point of care testing. So in spring 2020, it was changing times for the Acute Care at Home team. Early on, referrals increased by 81%. And from late March to the end of May, 350 referrals were accepted onto the team, of which 20% were COVID positive. This represented a huge increase in numbers to the team and obviously increased fears and anxieties around the challenges that were ahead. So the Acute Care at Home team responded then by starting a full 7-day service and increasing its support to GPs and care homes. We also started virtual monitoring of asymptomatic positive care home patients and changed to once per day antibiotics instead of 3 times per day. We amalgamated the team to work closer with specialist teams such as heart failure and respiratory teams, and developed a single point of contact telephone line for access to these services. We also introduced the PPE buddy system to improve safety and reduce anxiety, and we increased flexibility around longer working days and weekends to increase capacity. As OTs then, AHP face-to-face input was still considered vital for the majority of our patients given the acute nature of their illness. We continued therefore to assess and treat patients at home. We did, however, reduce face-to-face time and use telephone and virtual consultation where possible. So some reflection on the first wave then. Of the COVID positive patients that were admitted to the team, sadly 29% passed away. However, 71% went on to recover. A survey completed with staff found that there was better team working and increased flexibility within the team. Also, our team data and research has been presented to the British Geriatric Society and will be presented at the forthcoming Hospital at Home conference. The entire team has also underwent a debrief during the summer in preparation for the second surge. Feedback from the patients, their families, GPs and nursing homes has thankfully been overwhelmingly positive, and some of that is displayed below. And for OTs then, what's next? So we've taken the time then to reflect on the first wave and think about what we do differently. We're now gathering evidence and best practice research about providing rehabilitation to the recovering COVID patient. We're well aware of the deconditioning pandemic and are seeing some of these patients being admitted to the team. OTs and other AHPs are well placed to provide rehabilitation to these patients. Lastly, we have strong links with intermediate care. We can refer the deconditioned post-COVID fatigue cases onto them for to continue their rehabilitation journey. Thank you.
Hi, my name is Grania Forsyth and I manage a team of reporting radiographers in the Southern Trust. I qualified as a radiographer and then went on to complete a PGD and Masters to upskill to report X-rays. Public Health England states that radiographers are involved in 80% of all patient pathways. Never is this more relevant than in current pandemic, where radiographers are performing chest imaging in suspected COVID cases. The demand for imaging has increased dramatically whilst the radiology workforce has remained static. A radiologist is a doctor trained to report X-rays. This has created a significant gap between capacity and demand. To bridge this gap, Northern Ireland spent 9.3 million in 2019 in insourcing, outsourcing and locum costs. This is equivalent to the salaries of 103 whole-time equivalent consultants. This is only a short-term fix. We need to spend money wiser going forward on upskilling radiographers. Here are some examples of skill mix. Radiographers can upskill to report in many of these areas, all of which are happening in Scotland and England, and less so in Northern Ireland. Other collaborative working involves speech and language therapists working with radiographers to assess a patient's swallow, musculoskeletal ultrasonographers working with physios to successfully perform steroid joint injections, and plain film reporting radiographers working closely with emergency nurse practitioners and physios in the emergency department and GP practices to provide instant reports resulting in timely treatment for the patient. Breast consultant radiographers are the only consultant radiographers within the diagnostic field in Northern Ireland, and they report breast cancers. There are other radiographer-led lists where no radiologist is involved in the pathway. A more recent development allows the GP to refer a patient for imaging after trauma to a non-acute site. The reporting radiographer gives an instant report resulting in the patient returning either home or back to the GP for treatment. This alleviates footfall to the acute ED setting, and patients are happier attending a quieter healthcare setting. These are some of the benefits of skill mix, all of which have been evidenced in numerous articles. The patient will be happy with a correct diagnosis in a timely manner. So going forward, I believe we need increased funding to upskill radiographers and implement the 4-tier structure across all of radiography. We need radiographers to invest their time and effort to gain this additional qualification. The service needs to be well governed and audited, and the result will be optimum activity with timely, accurate results, resulting in a very much improved patient journey. Thank you.
Hello, my name is Jill Stewart and I am one of the Health Improvement Dietitians in the Northern Health and Social Care Trust. The Public Health Dietitians Group in Northern Ireland is commissioned by the Public Health Agency and works to influence public health at a population level through nutrition education in various formats. Some of the key areas of our work are obesity, food poverty, childhood nutrition, public health policy, and ensuring nutrition standards across health and social care settings. Hopefully, the next few slides will give you an overview of how we have adapted to rebuild public health dietetics during the COVID pandemic. In March, we found ourselves unable to continue delivering the face-to-face training and public-facing work that we were used to, but there was even greater need for nutrition education due to COVID, with issues such as food poverty and obesity highlighted frequently in the media. We carried out a regional scoping survey to identify the key nutrition issues affecting communities across Northern Ireland during the pandemic, and these were highlighted as being healthy eating, cooking low-cost meals, and feeding the family on a budget. Nearly half of trained tutors were also unable to continue running programmes such as Cook It and Food Values due to the COVID restrictions, and 95% of those who responded were interested in receiving support from dietitians. This enabled us to develop new tailored resources. We embrace new technology such as Zoom to deliver an innovative regional series of nutrition webinars based on the topics identified in the scoping survey, and nearly 300 individuals have already availed of these. Online evaluation survey using Citizen Space has been a quality improvement initiative, enabling us to evaluate these new ways of working. Nutrition related content, such as the webinar flyer and the breakfast infographic pictured, have been shared on the Health and Social Care Trust social media channels, making evidence-based nutrition information more readily available across Northern Ireland. Community nutrition programmes Cook It, Good Food Toolkit and Food Values have all been adapted for virtual delivery, with new online resources developed, including time-lapse videos for recipes such as the chicken curry pictured. This has enabled tutors to continue running group sessions, albeit in a different manner. Footballer Marcus Rashford raised the important issues of food poverty and holiday hunger during the pandemic. Public health dietitians responded by providing a food bank helpline, involvement in holiday hunger summer schemes, and providing and developing webinars such as Feed Your Family for Less with food budgeting messages. Hopefully, this has given you an idea of how public health dietitians have adapted to continue reaching as many people as possible with nutrition education during the pandemic. It has been a time of uncertainty and challenges, but also an opportunity for teamwork and innovative service rebuilding, of which I'm really proud to be part of. Thank you for listening.
I am delighted to introduce our next and final presentation. We have a service user who is going to tell us about the impact of AHPs on his recovery during COVID.
I'm here to chat about my experience with a few of the allied health professionals in Northern Ireland. I have good bit of experience with soma therapy, chiropody, occupational therapy, and other topics. AHPs in this country play an absolutely essential role in the healthcare system, and my care definitely would not be the same without them. I take part regular therapy sessions, which I find has helped me face problems with a low pressure, creative and playful environment. Occupational therapy has aided me in keeping my walking skills up to scratch provided with the correct equipment to do that. Therapists comes to see me quite regularly, and I found their work with me very effective, as well as the orthopic team working with me, who have done vital work with me in preserving my eyesight. I have found these professionals to have great skill sets and also to have been very helpful in maintaining my quality of life. They have been personal, approachable, and made me feel comfortable once I've been on to their care.
Thank you to everyone for all their presentations. Can I remind you all to do the poll of the 3 questions now? And Jenny, I believe we've got 2 questions that have been raised, which you have agreed to answer for us.
Yes, we do indeed have some questions for Jenny today. My name's Ciara Gallagher and I'm the Head of Office for the Royal College of Speech and Language Therapy here in Northern Ireland. And before we do give our questions to Jenny, we've got 2 so far in the chat. Can I just say what an amazing webinar this has been. I don't know about yourselves, I put it into the chat, but it goes to show the huge diversity, the transferability of our skills as AHPs here in Northern Ireland. And in terms of the rebuild and rebuild back better, I really firmly believe from what we've heard, and obviously that's only a tiny part of what everybody does, I think we're in a great position for moving forward and looking at the reimagining of our HSC. So well done to everybody. And I suppose just one other thought that I had was the importance of you don't know what you don't know. And as an AHP, as an SLT, there are things that I have learned here today from my fellow AHPs, and I am already an AHP. So I think it's really important to share these messages at whatever tables you get to in your jobs as well, and very much wear that second hat for AHPs. As Jenny said earlier, we are allies and we're stronger together and we can support each other together. So now that my little broadcast is finished, I'm going to ask Jenny her question. And it's really around, Jenny, the rehabilitation and the core role that AHPs have in rehabilitation. And given that Scotland have produced a framework for supporting people through their recovery and rehabilitation, both now, during and after this COVID-19 pandemic, I suppose what we're interested to know from a Northern Ireland perspective is what plans do we have to develop rehab as a key strategic area, and indeed how can we as AHPs be core and embedded in this framework?
Thank you, Ciara. I had a brief panic moment there when my audio stopped working and I thought, or my microphone stopped working, which has never happened to me before, but sod's law. Yes, Ciara, a very, very pertinent question, and one which I have to say the Federation have been vociferous in their lobbying of the Health Department and to the Minister on behalf of the allied health professions collectively. Has been their desired request for there to be a rehabilitation framework or strategy within Northern Ireland. And you'll have had a number of responses, but I suppose what I can first do is give you an indication of what the position is. So you'll be aware, or it's an opportunity to let everybody be aware, that the Ministers has specifically asked the Chief Medical Advisor or the Chief Medical Officer at the beginning of the summer to set up a series of workshops or to set up an engagement process to look at what rehabilitation services were available in Northern Ireland, what did the workforce, the stakeholders believe rehabilitation need was. And then he asked for that, the Chief Medical Officer asked the Strategic Clinical Advisory Group to look at that. That's a group that I sit on, I'm a core member of it. And the approach taken by the Strategic Clinical Advisory Group was to run a series of workshops over the summer months 3 in total. The first one, which was a failure, an IT failure, but what was made really clear to the entire workforce and to all of the stakeholders was the Strategic Clinical Advisory Group, while they held a number of consultation exercises, they were open to written statements, both of evidence, local experience, local audits, professional guidance, and all of that has been collated. The Strategic Clinical Advisory Group is considering that, and the Minister has asked for recommendations to come from that consultation event to be given to him for him to make a decision on what the next steps are. So I'm not aware that the Minister has made a decision on that. I suspect these certain days, I don't believe it's going to be a priority just today or tomorrow. However, it is a priority for the professional officers within the department, because while this is very much within the arena and within a priority for allied health professions, it is also a significant priority for particularly our medical colleagues and those in the psychological therapies. A number of the professional bodies, as did a number of individual clinicians across the system, have made written and verbal communications to my office and to the private office about a concern that the initial consultation was focused on patients which had been admitted to hospital as a consequence of COVID, expressing that this was merely the tip of the iceberg, that there was a much bigger demand across the community. That message has been heard, and that message I expect will be very clear in the recommendations that go to the Minister. And it would be remiss of me not to say that the allied health professions from right across all of, a wide range of professions contributed significantly to those workshops, both on the day, but by far the largest communications we've got have been from individual teams and professions across the service. So all of that will be taken into consideration. I can't give you an answer as to when, but it is being considered.
Jenny, that's fantastic, and we really do appreciate everything that you do representing us at those tables. And I'm sure I say that on behalf of everybody here on the webinar today, and indeed to all our leads in our AHPs, with Michelle Tennyson as well at the PHA. As you say, we're stronger together. And before I let Leandra just say one thing in case we forget, can we just thank as well Andy, Fiona from the CEC for making this all happen today, because if you were relying on me for my technology skills, that would not be happening. So just fantastic, and Pippa for the event as well, setting it up. Definitely, we're definitely working together in good collaboration. Thanks.
Good afternoon, everyone, and I would just like to reiterate what Ciara said. Congratulate all our presenters today. You've been amazing, and I think this webinar has just really radiated positivity in a time when there is quite a lot of negativity around. So well done to everyone. I would just like to ask Jenny a question. AHPs are core to the recovery and rebuild solution in Northern Ireland, and they have more than played their part during this pandemic, as well as having a key role in rehab, pre, during and post COVID-19. Do you think that supporting AHPs to work at the top of their licence, as described in the AHP Advanced Practice Framework, is more crucial now than ever? And what has been done to progress this? Thanks.
Thanks, Leandra. I thought for a moment there my question was going to be really simple, and it was going to be a yes until the second part. So yes, absolutely. The need for the allied health professions to be at the top of their licence and pushing what the top of that licence actually is absolutely vital. We've heard from a number of presenters this morning. Probably the one that sticks out in the context of advanced practice and the impact that it has had not just on their immediate service, but on the performance targets, on maximising resources has been Gráinne. The reporting radiography example of where advanced practice really can be, absolutely transformative across the system. We're seeing that across a number of professions, primary care, the first contact practitioners, the need for first contact practitioners out with physiotherapy, but also in secondary care as well as just primary care, mental health. I can't list all of them, that they're immeasurable, they're right across. Things like the prescribing agenda are key to it. So there is an absolute need for AHPs to be at the top of their practice and working to the top of their licence. The emergency COVID legislation actually helps that and supports that. In terms of what we're doing to support it, Leandra, you'll be aware that yes, there's the advanced practice framework. I'm not sure that I should say that frameworks, policy, everything else is all very well, but if it's sitting on a shelf, which I think is your second question really, is what's actually being done to address that? What's being done to actually put that into practice? So you'll be aware that the postgraduate education commissioning process, Michelle's on the call as well, and Michelle chairs that for me, that is pivotal in actually being able to plan, and probably even more important that we use that as a forum to articulate what the need is for advanced practice across all of our professions, and being able to articulate where that benefit is. I don't believe that there is a challenge at all within the system to releasing and enabling AHPs to work at the top of their licence. I think we have become far better at being able to articulate what that means and the impact of it, and it's being able to hone that articulation that is absolutely key. I think we've even seen that today across all of the presentations. So it's harnessing that and being able to lay it at the door of all of the key policy areas. It's really important. I mean, really, look, it's great today that you've highlighted themes that link really well to New Decade, New Approach, to the to the Rebuild, Restart agenda. Those are the people that are actually wanting advanced practice. The orthopaedic network leads literally couldn't get enough advanced practice. The imaging review can't get enough advanced practice. Primary care are calling out for advanced practice. Mental health are, so that there is absolutely ample, opportunity. As a professional group, we also have to, while we have that ask, there is also a need for us as a group of professions to actually also realise that we can't do everything. So at the other end of that spectrum is the need for us collectively to let go and to stop doing some of the work that we're doing. If we're going to work at the top of our licence, we have to be able to articulate and describe what work is not at the top of our licence, and we need to be able to, come to a point where we're comfortable letting go of work that is not necessarily what registered professionals need to do. So it's encouraging that in a lot of the regional strategic business cases that are ongoing at the moment as part of the Rebuild, that the therapy support workers, the support workforce is now you can see a real desire and need for that, and that needs to be there to be able to support the advanced practice piece. So, I mean, I'm happy if there's time to take any further questions or to hear your thoughts on that, Leandra.
Thanks, Jenny, that's great. And I think we just have to keep on pressing for more funding for advanced practice throughout all the AHPs. And it's particularly important after seeing all the presentations today. We can definitely see how vital it is for our health service. I'm not sure if anyone has any other questions. If you want to write them in the chat box.
I have actually, I'm going to invite Michelle Tennyson in, has made a comment and she'd like to discuss it. Michelle, if you're there.
Yes. Hi colleagues. First of all, AHPFNI, fabulous, absolutely fantastic to bring us all together today. It's been a brilliant webinar, and Jenny, to you also for setting a very clear set of strategic messages for all of us. And I think I'm leaving this webinar actually feeling so much more energized than I certainly was coming in this morning. So thank you personally for all of that. I had put in the chat line a piece around patient experience and public involvement, and I was really struck throughout all of the presentations the commitment that we all have as AHPs to advocating for our service users and carers, that that approach with the shared responsibility. One of our colleagues made reference to that, and co-producing and co-creating supports for our service users and carers. And one of the things that Jenny and I have talked about quite a lot in the past is, you know, how do we support the delivery of our message as a group of professions, but also the added work that we do, and that advocacy, that commitment that we have to our service users and carers and hearing their voices. I think there's something more that we might be able to do to bring that into a space and create an energy and force in the system that accompanies that role that we have within our individual professions, and certainly being responsible for the implementation of involvement and experience policy across the system. We're crying out for champions, and I believe that we could move en masse in this space. And I'm just putting out there whether colleagues feel that that's something that Jenny and I could, I suppose, work out how we might do that. So just popping that out there as a proposal.
Michelle, we're open to the challenge, so we are, and we can help you in any way that we can. We will certainly, I'm sure, bombard you with ideas there, so we will, and thank you for the opportunity. Okay. So we've come now to the end of our webinar. I have a big thank you to the Minister, Robin Swan, to the Chief Allied Health Professions Officer, Jenny Keane, to all our presenters and our service user. To the CEC, Fiona and Andy, for providing this platform and pre-recording some of the presentations. To Pippa McCaig at the PHA for organising the Eventbrite link. Last but not least, I wish to thank the AHPFNI team, who have worked really hard in the background putting all of this together. What a wonderful way to celebrate International AHP Day. I hope you all stay safe, and thank you again.